From the American Association of Nurse Practitioners, I'm your host, Dr. Sophia Thomas, and this is NP Pulse, the voice of the nurse practitioner. Welcome to NP Pulse, AANP's official podcast, bringing you unique nurse practitioner voices and expertise on issues that matter to NPs and to our patients. Improving outcomes for those living with advanced illness has increasingly become a stated objective for many top research funding organizations in the United States. Regardless of the clinical environment, healthcare providers describe difficulty in having such vulnerable conversations, and this skill is not routinely taught in educational arenas. Join us on NP Pulse as we speak to Martha Francis and Sarah Summers on how to have difficult conversations with our patients. Welcome to NP Pulse. I'm so glad you were able to join us today.
Thank you so much for having us. We're thrilled to be here.
Great.
Honored. Yes, thank you.
Wonderful. Well, before we get started, I want our listeners and viewers to know who we are speaking to today. I think this topic is just amazing. So first, go ahead and introduce yourselves.
My name is Dr. Martha Francis. I'm a nurse practitioner. I have a PhD in nursing, and I've been nurse practitioner for about 25 years, and I've worked in oncology nursing for almost 30 years. And I have currently been in a practice in Baltimore, Maryland area. So that's where we're coming from.
Great.
I'm Sarah Summers. I've been a nurse practitioner for 7 years, and I worked in emergency medicine for 15 years, and then I changed over to radiation oncology for the past 2 years. And just very excited to be here.
Great. Well, I think your topic is so interesting. We're going to talk about how to have difficult conversations with patients. And I have to ask, how did this topic come to rise? How did you get involved in it? And more importantly, how did you two meet? Do you work together?
Yeah. So I have been so fortunate. I changed over to radiation oncology, and Dr. Francis has been so welcoming and such a great colleague to work with. And even though her having difficult conversations is a different blend than my difficult conversations in the emergency department, but the underlying foundation is the same. So that's kind of what we're going over, to teach people how to do that.
For me, this difficult conversations and how to support families and patients in a vulnerable space during illness has been a career solely developing throughout my career. Through my PhD is when I really found a framework to articulate what exactly is it from clinical practice that drove me to hone in on this topic itself. So I think this has kind of been a slow evolution over time, and Sarah and I together have really packaged it in a way that brought it to life.
Great. And so you've kind of mentored Sarah?
I think in certain aspects of practice, she mentors me in her emergency medicine background, but in the oncology world, although she's an expert clinician, the oncology setting, again, you go from an expert down to novice when you're in a new area. So we spent a lot of time unpacking different clinical situations and talking through what works, what didn't work, how do we make those experiences better, not just for patients and families, but I think also as providers, we're constantly learning, and that's part of being a professional.
As nurse practitioners, we always get education about how to treat illnesses, and certainly treating advanced illnesses is important, but we're now discussing how to have difficult conversations about advanced illness with patients. Why do you think it's so challenging for healthcare providers to have those difficult conversations with patients about these advanced, sometimes life-threatening illnesses?
I think that we are people pleasers, and that we want to be able to deliver good news to patients. We want them to have great outcomes. We want them to have longevity. And that's not always true. And so I think that having difficult conversations is important and pertinent to many aspects of care, and it's not really taught very often. Sometimes you have to get additional training on it. Sometimes it's just on-job training.
Another caveat to that I would point out, this area of interest for myself, it's not just that it wasn't taught. I think this challenge in clinical practice, regardless of the serious illness, exists but I don't think people recognize how important it is. And for me, in my clinical experience, I would frequently find myself sitting with patients and families and feeling the emotional tension and the distress. And in that space, unpacking those conversations and what's there, and walking out of that experience confused by how is it this person is so far into their illness and just now comprehending it, and being struck with the amount of time they've lived with that distress, that it's been unaddressed or unacknowledged, and that it's a missed opportunity as providers. We use medical science to treat illness, but there are other aspects of the illness that we're not addressing. So for me, this has been definitely a personal passion to try and help support patients and families to live better during illness, not just cure them.
Yeah, and that's so important. A lot of this is about communication, right? And we learned when we were in nursing school about how to have therapeutic communication and conversations, but we haven't learned to this degree about how to have difficult conversations. And when you speak, you talk about furnishing healthcare providers with tools to help them. What do you mean by furnishing them with tools?
Over the years of people have really started to understand the lack of significant communication, or patients are not articulating what's really important to them during illness. Communication has been elevated to a higher level need within the clinical environment. And I think that we're now learning how important it is, and that we need help for providers, not just the language, but also let's come up with a guide for how to do that. But really the takeaway message is about understanding there are frameworks to help support you in those conversations, and then with practice and discerning what fits right for you on a personal level, but also for your setting, and tailoring that to your setting and your environment.
So you talked about 3 frameworks. What are these 3 frameworks?
3 frameworks. One is called the Ask, Tell, Ask framework, and that's basically asking patients, understanding, telling the information that they're inquiring and what they're explaining they want to know, and then asking them to reiterate that to confirm their understanding, so that at the end of that conversation exchange, questions have been answered and the patient walks away feeling like they've had their needs addressed, and there's a better understanding of what's actually happening within the clinical exchange. Second framework is called the Spikes model. Similar, has different, it's a little bit different framework, but the gist is the same. You're inquiring from the patient what information they want to know. You're relaying that information back, and then you're closing the conversation with summarizing the conversation exchange. And then the third framework we discuss is called the Serious Illness Conversation Guide. And that is another conversation framework, mirrors similar aspects to the other two. What's unique about the Serious Illness Conversation Guide is it also has a step that intentionally explores the patient's goals and values during illness, which their framework emphasizes the importance of patients thinking about, contemplating, and relaying that information to their providers about goals and values, so that there's a collaboration between patients and providers to tailor treatments that fit and respect the patient's wishes, so that they're living according to their own personal goals and values, not what the institution or medical environment necessarily prioritizes.
So, Sarah, you've used these frameworks in practice. Yeah. I guess each one you'd use each one individualized based on the needs that you determine the patient might have. So you're assessing your patients and saying, okay, I may use Ask, Tell, Ask on this patient, and another patient use that, or a combination of all 3. What is the most memorable, I guess, experience you've had in using one of these frameworks as you work with your patients?
So I recently had a lovely lady who had metastatic breast cancer and had metastasized to the brain and then to the spinal canal, which has a very, very poor prognosis. And so we were queuing her up for radiation for the brain and the spine. And then she was going to start chemotherapy afterwards, and she just didn't feel well. And so she kept pushing off the start date for things, which when you already have a poor prognosis, time is not, pushing things off does not give you time for anything. It just shortens things. So she didn't show up for radiation for like a week. And so I kept calling her, and every day I was like, I don't feel good. I'm going to come back. I'll come tomorrow. And so I finally had a conversation. I was like, ask. Tell me what's your understanding of your disease right now. And her understanding did not correlate with reality. And so that was a very tough conversation. And unfortunately, it was over the phone because she felt so poorly, she couldn't even come into clinic, which made things even more of a challenge. But at the end of it, it was very emotional, I think, for all of us involved. But at the end of it, they thanked me, and they're like, hospice, I think, is a better reality for them than pushing themselves to get the chemo and to get the radiation. So I think that was a time where I had to use our framework. I was remembering going through all the steps while I was chatting with her. And it helped with it because having a difficult conversation can be really intimidating. And I think by having just a foundation and some bones to go off of, it lets you to kind of fit it and fit what goes to the situation and what you're comfortable with.
So you both have had experiences, obviously, where you've had to tell somebody they have cancer or they have a terminal illness. I'm sure that doesn't come easy, and that takes practice and getting used to being comfortable, even bringing those subjects up with patients. Does it get any easier?
What gets easier is resting in the uncomfortable, and that as human beings and as nurses, to see suffering, to witness suffering, to feel that suffering, it's painful, it's uncomfortable. And so to have these delicate conversations and not be changed from that, I don't think it's possible to be a human and not be changed by witnessing somebody's suffering. The way over the years that I personally cope with that is I'm sitting with them in that suffering and discomfort. And it can be really painful and emotional. I can support them in that. And then when I walk away and I maybe have to have a timeout and wipe my tears away, I then follow that with thanks that I was able to be there with them in that. Because if we are not, who is? And if we don't support the patient in that, there's a family around that patient. And it's not just the patient that suffers, it's their family. So I will die on the sword for that. Right? I throw myself in the fire knowing that it's going to make a difference for the patient and the family. So that's what keeps me going.
And to add on that, it's uncomfortable for a reason, right? And it doesn't get better, but you shouldn't avoid it because it's hurtful for everybody that's involved by dancing around these things until bad outcomes happen. And like Martha said, you might need a minute, and that's okay. Difficult conversations are okay, and it's okay to not be enthused by it, but you should still be having them, and we should still be having them as providers.
Yeah. So if I'm a nurse practitioner and I am having to, and I am a nurse practitioner, so if I have to break bad news to a patient, I get, I see results. Oh my goodness, this patient may have cancer. I'm going to have to try to get them into oncology, but goodness knows how long that's going to take. How do you have that conversation with the patient?
I usually start by setting the stage, and that's what all the frameworks start with, is bring them to a space. So whether or not it is in person, which is ideal, or over the phone, which is not the best, but you do what you got to do. You got to meet the patient where they are and what they are able to do, and make sure you have the time to sit there, because you need to listen to them, and they also need to be able to have that space to process it and ask pertinent questions.
Mm-hmm. And another layer I would add in that is reassuring them that when you're giving this bad information, they're not alone. Even though this isn't the information I was hoping to give you, I want to reassure you that I'm here with you and I'll support you, and I'm still here after we have this conversation. So you'll be there to support as they unpack and process the consequence of that information, and then help guide them to get to the next provider layer that they need. I think it's the reassurance and support. Building that relationship is key.
Yeah. And I think that's what nurse practitioners do so well.
We do. This is a hidden opportunity, another avenue for nurse practitioners to really stand tall and excel. Declare this as another avenue to show our excellence in the healthcare environment. We balance the scientific knowledge with human caring. And that, to me, is at the heart of compassion and communication and sitting with people in vulnerable spaces. And this is what we do every day. We just don't have a label on it.
Yeah.
And the other piece of that, too, is that it's not always terminal illness, right? Like, I've had difficult conversations with diagnosing someone with herpes, HIV. It has a stigma. Like, it's uncomfortable. Like, the patient...
It's life-changing.
It's life-changing. Absolutely. And so just because it's not terminal, it is life-changing. And you need to approach both in the same way, with compassion and understanding and time.
And being sure the patient at the end of that conversation understands.
100%.
I had to, when I was a young NP, I had to tell my first boss that he had renal cell carcinoma. And unfortunately, I was just on him, you've been smoking for years, you at least need a chest x-ray. And so, he finally agreed to it. And I got the report back on a Friday, and you don't give bad news on Friday. That's not good. And so he called me Friday afternoon at 3:00 and said, do you have my report back? And I couldn't lie. And so I just had to tell him. And, very young, had been practicing for a year and a half. And so it was very, very challenging, very stressful. But you have to be honest and be sure the patient knows and understands. So I think that's just so important. I don't know what I could have done anything, differently at that time. But is it true, don't give bad news on a Friday if you can help it?
I don't think there's any good day.
I don't think there's that good day. I think another perspective I would add, although it's not ideal on a Friday, it would be worse for the patient if you made them wait till Monday.
Oh, 100%.
Another 2 days of suffering and worrying.
Mm-hmm.
That's usually the thing that pushes me to actually pick up the phone or sit down and have that conversation on a Friday, even though nobody wants that conversation on a Friday.
Absolutely. I'm so glad that you all speak about this and are training nurse practitioners how to have these difficult conversations. What are some things that we can do as nurse practitioner leaders to help spread the word and educate more people?
I think one of the excellent tools that we're doing, not just teaching the frameworks, is focusing on modeling the language, because it's not enough to just understand the framework. You have to practice and model, and hearing somebody use the language that can ask the question has been very helpful for me as I've been learning in this arena. And I think that's a tool I'm hoping others will learn also, to be able to practice the language in their own clinical environment, in their own family environment. Think about having a difficult conversation with your teenage child about limiting social media or taking their phone away. That's a very difficult conversation, but you can practice these tools in that setting. And so it's for everybody. If you're a human, you're a parent, a friend, lots of opportunities for practicing.
I think, like what Dr. Carnes said, it's nice to model that behavior and then be a source for your peers, and then move it along. We're fortunate to work in an academic institution, so we get to teach residents with things, and I think this is also something that they struggle with. So by kind of bringing them in and mentoring in those pieces, sometimes that's something that we can impact their care with as well.
Yeah. And then finally, it's so important to have clear, open dialogue with our patients. And this is something that you've spoken on before. What are some more benefits of that?
The biggest benefit to me is, in our world, in the oncology setting, my goal is to help people live well during illness. In the clinical environment, unintended consequence to us building that comfort and skill of speaking on vulnerable content is, as we practice that in our patient exchanges, there are other staff surrounding us in the clinical environment that also witness these discussions, may hear it. So not only are we teaching patients and families how to engage in this vulnerable space, we're also teaching physicians, residents, nurses, medical assistants, anybody around us. And my hope is, like dropping a pebble in the water, that ripple effect goes out and we have an incredible power in using our language and our skill to impact the environment around us.
And wouldn't you say a big part of this also is that relationship you have with the patient, the trust?
Yep. I think that having a rapport with patients and having an honest dialogue with patients and being a source of honesty, any communication and support is phenomenal.
Exactly. Well, I appreciate the both of you joining us here in NP Pulse today, and I'm so proud of the work that you're doing, sharing this message with people, teaching people how to have these difficult conversations. And I think it's something that, you're right, we can use it in our professional life, but also in our personal life as well. So thank you so much for joining us today.
Thank you for having us. It's been an honor.
Thank you for appearing on NP Pulse, Martha and Sarah. And thank you all for joining us today. Please subscribe to this podcast, share it with your friends and colleagues, and check back regularly for new episodes. And as always, be kind, be safe, be effective, and be the voice of the nurse practitioner.